So what does chronic kidney disease mean for our diet and our medicines? Because I told you about medicines and I told you about all the nutrients that are changed. So if our kidneys aren't working, we may need a very low salt diet. Um, because if we can't get rid of extra salt, the only way to protect ourselves is not to take extra salt in. Uh, and and usually, in addition to a low salt diet, we'll usually need medicines to help push our kidneys to work harder to excrete salt. And these are diuretics, or what most people will call water pills. Um, we may need a low potassium diet, although many people don't. Although it's a subtle point, but people who have chronic kidney disease because of diabetes will often need a low potassium diet. We need to avoid foods that are high in phosphorus. And a lot of these we think of as being meat. But in fact, I want to point out that, that there are lots of foods that have phosphorus hidden in them. And chief among them are some carbonated drinks and actually some other prepared drinks like lemonade mixes, for instance. Even when, and it's interesting, even they're not on the nutrition labels, not that anyone reads nutrition labels on soda cans. Um, but, but it's scary how much phosphorus can be in them. Drink water. Uh, uh, because the kidneys were excreting acid, you don't really have another good way to excrete acid. And a lot of people with chronic kidney disease need to take bicarbonate to make up for that. And may need to take a special form of vitamin D to make up for the fact that the kidneys are not activating their vitamin D. Uh, and, uh, and, and patients with advanced kidney disease who would be anemic actually take medications like erythropoietin that will tell the marrow to make blood. Uh, this is really complicated, being a patient with CKD. It can look like this. It's a full-time job to keep all the medicines straight, to follow a strict diet. And our kidneys do this all the time without us even knowing it. If you look at all the patients in the United States with chronic kidney disease, and this is about 15% of the American population. About 40% of them have it because of diabetes. About a quarter of them have it because of high blood pressure. Glomerular nephritis is a family of diseases usually caused by the immune system that attack those glomeruli that I showed you in the kidney, and then other causes is kind of a mix. If I were to look in American Indian populations, diabetes wouldn't account for 40%. It would account for over 2/3. And high blood pressure for most of the rest. And this is what we saw in the Strong Heart study. So how do we find and diagnose CKD? Well, only if you look for it. And we measure kidney function usually by looking at creatinine in your blood test. And a normal creatinine is about 1, and a normal GFR is about 120. And there's this funny relationship. It's not just a line relating creatinine to GFR, it's a curve that looks just like this. And what you'll see is that even when you go from 120 to 60, which is that you've lost half of your kidney function, you've only gone from 1 to 2. And then it gets steeper and steeper. So a creatinine is not a good way to find early kidney disease. It's a very sensitive way to find more advanced kidney disease. We really want a way to find damage when kidney function is still normal. And the best test we have for that, not in everyone, but certainly in people with diabetes, is albumin in the urine. And I told you that the filter, or the sieve with the celery in it, of the glomerulus, keeps albumin in your blood and doesn't let it in your urine. And when that begins to get damaged, albumin can leak into your urine. And so we can measure that in the laboratory. And albuminuria means that there's injury to the blood vessels in the kidney. Any albumin in your urine is too much albumin in your urine. And even when research in other populations had shown that a certain amount of albumin in the urine was dangerous, we showed in the Strong Heart study that even lower amounts of albumin were dangerous, and were a way to predict kidney disease and also cardiovascular disease. And so people have come up with scoring systems for this and clues to how do you know is CKD getting worse? Well, if the creatinine goes up, it's getting worse. If the albumin in the urine gets higher, it's getting worse. Because the kidneys are so important to blood pressure, if it gets harder and harder to control blood pressure, if you need more and more blood pressure medicines, kidney function might be getting worse. There are other blood tests. And, uh, and GFR is usually considered abnormal or kidney disease when it falls to 60 from 120. And so this is kind of misleading because it says everything between 60 and 120 is normal, and that's not true. In fact, around here is where I would say it's abnormal. The problem is the creatinine test can only detect it reliably when it's fallen to here. This is the range of chronic kidney disease down to about a GFR of 15. And beyond that is kidney failure. And at that point with kidney failure, in order to stay healthy, you need either dialysis or a kidney transplant. And dialysis and medicines and diet can control all of these symptoms. But again, it's a full-time job for what our kidneys otherwise do well. And so these are we tend to keep score of progressive kidney disease by dividing it up into stages by just how bad the GFR is, how it falls all the way to kidney failure. And I want to point out that kidney failure is not a death sentence, and that in fact, people feel really crappy here. And dialysis or transplant, if people decide to do it, makes almost everyone feel a whole lot better. But it's important to remember that at every stage of chronic kidney disease, the risk of cardiovascular disease or of death from cardiovascular disease is actually bigger than the risk of going to kidney failure. And that means that controlling cardiovascular disease risk factors in people with CKD is really, really important. And what do we know from Strong Heart? Well, in Strong Heart, we found that either albuminuria or a low GFR are strong predictors of cardiovascular disease, including heart attacks, stroke, heart failure, and amputations. Just recently, we found that chronic kidney disease that gets worse more quickly predicts even more cardiovascular disease, which seems to make sense. Diabetes and how well sugar is controlled and high blood pressure and how well it's treated, along with smoking, are strong predictors of chronic kidney disease and of chronic kidney disease that gets worse. These are good not just for diabetes and heart disease, but for chronic kidney disease. The one that's not here, that's really important, is taking your medicines as they're prescribed, because the medicines actually help a lot in slowing the progress of chronic kidney disease. And here's the part that I think a lot of people are surprised when they see. And we all know that, that Native peoples have a lot more diabetes than any other race or ethnicity. And these were some data. They're 10 years old at this point, twice as high as whites in the general population. You also know, and we all knew, that kidney failure from diabetes in natives was higher than everyone else. But in fact, over the stretch from around 2000 to 2013, it's fallen more in American Indians than in any other population. That's still too high, but the improvement is dramatic. And the improvement is dramatic because I think everyone got on board to pay attention to all the details to get people care that they need. It may not feel that way. I know, our healthcare providers are stretched, the systems are stretched, they're underfunded, but people paid attention to the right details. Uh, and and I'll tell you that so far, among the drugs that have made the biggest difference are ACE inhibitors and angiotensin receptor blockers, which are blood pressure medicines. All of these drugs have names that end in April, and all of these drugs have names where the generic names end in sartan. Uh, and uh, and it was only between 1993 and 1997 that the first research was done showing that these slowed kidney disease progress in patients with diabetes. And then by 1999, three-quarters of patients in the IHS with diabetes were on these drugs. Later, we showed, and others, that all patients with hypertension and diabetes should be on these as the preferred drugs, and it quickly became the case across the IHS. Later on, it was shown that any patient with diabetes who had albumin in the urine should be on these drugs. And very soon thereafter, it was the case. These are numbers of people getting the right drugs that exceed that in almost any other healthcare system in the world. So where are we now? What's now? What's next? This is sort of life simple sevens stated another way. Diet and exercise to prevent and control diabetes and CKD. Diet, exercise, and blood pressure control with medications, including ACE inhibitors and angiotensin receptor blockers to prevent and to slow CKD. Diet, exercise, blood pressure, and cholesterol control to prevent the CVD that is, in fact, the thing that kills most patients with chronic kidney disease. Early detection using lab tests like urine tests for albuminuria to find CKD before there are any symptoms, because symptoms happen very late. And if we wait till we feel sick, then we're really sick. And I told you about ACE inhibitors and ARBs. And I want to actually look a little into the future. There are two new classes of drugs that have just within the past months to a year been shown to slow chronic kidney disease and decrease cardiovascular disease, even patients who are getting all of the current right therapies, including ACE inhibitors and ARBs. One of these has just been approved. The other one will be approved, I think, within the next couple of months. And these slowed the progress of chronic kidney disease by a third on top of the best treatment. So this may give people years more of health with chronic kidney disease. These drugs were not studied in American Indians yet, but the disease is the same. The other drug trials for ACEs and ARBs were not done in American Indians, and they worked identically in American Indians. And as Dr. Best told you, I'm actually particularly interested in research around new medicines. And there are drugs that are in early studies, and we're figuring out the mechanisms of action. And I think they'll be in clinical trials for CKD within just the next couple of years. So I just want to point out that there's nothing I told you this morning that that wasn't because of research that I was able to tell you. It's not because people are smart and know stuff or can just explain stuff that was in books. It got into the books because of research. And a lot of that research was actually pretty recent and done as clinical research with people.